All right, thank you. A couple disclosures. So the talk that I'm going to give you, the data has been supported by an NIH grant and a grant from Haemonetics. So to start out with, just to give you a little bit of background, basically this idea in trauma, in peripheral disease, and any sort of situation where we're clotting and bleeding, we're really using algorithms that are from like the 1950s, 60s, and onward. And there are other groups, such as the cancer group, for example, that have put a lot of time and effort into figuring out precision medicine and medicine that is specific to a person when they give particular drugs to save lives, and antiplatelet therapy. It's interesting. It's because in vascular surgery and in vascular trauma, we've got such futuristic options in terms of endovascular to revascularize people. And yet when you're talking about post this crazy thing, you've gone and saved someone's life and you've put all these stents in different places and all the endo stuff we talked about yesterday, then you just walk away and kind of close your eyes and MI, ischemic stroke, acute limb ischemia when your stent goes down, and ultimately amputation are all related to having clot. So basically you don't get that balance between not bleeding and not clotting. And that's really important in trauma because you've got people who've got head wounds, but you've also got people who you've just done some fandango on their leg to save them. So what's the sweet spot that you put patients at in order to save their life, but also save their limb? So the incidence of graft and stent thrombosis is dismal. It's up to 20%, which is significant because you're talking about a lot of patients, especially when you're talking about, peripheral artery disease on top of everything. Our population is getting older. So you've got patients that are not only going to have some sort of traumatic